And you. Okay, good afternoon, everyone. Thank you so much for tuning in to our October Health and Wellness Awareness Series. My name is Kayla Vargas, and I'm the program supervisor for the Women's Fund. Our mission is to provide free health and resiliency education for women and adolescent girls so that they can have the tools that they need to be advocates for their health. So we do this through focused seminars like today's presentation, as well as curriculum-based classes and publications. If you're ever interested in learning a little more about the Women's Fund, I highly encourage that you visit our website, thewomensfund.org. For today's presentation, I just want to go over a few housekeeping items. Please keep yourself muted throughout the presentation just so that we can limit any distractions. If you do have questions, you can definitely feel free to add those into the chat at any point. We will have an opportunity at the end for a question and answer session. So I'm going to go ahead and introduce our speaker for today. Dr. Sunil Patel is the Chief of Hematology and Oncology at Kelsey-Seybold. Dr. Patel earned his undergraduate degree in 1997 at Northwestern University in Evanston, Illinois, where he graduated with a Bachelor of Arts in Molecular and Cell Biology. He completed his medical degree in 2002 at the University of Pittsburgh School of Medicine, his residency in internal medicine in 2005 at the University of Texas Southwestern Medical School in Dallas, and a fellowship in hematology oncology in 2008 at the University of Texas MD Anderson Cancer Center in Houston. Prior to joining Kelsey-Seybold in 2019, Dr. Patel cared for his patients at the MD Anderson Cancer Center, where he was an associate professor and deputy department chair of the Department of General Oncology, Division of Cancer Medicine, and Center Medical Director of MD Anderson's West Houston, Katy, and Memorial City locations. Dr. Patel is a member of the American Association of Physician Leadership, American Society of Clinical Oncology, American Society of Hematology, and Health Volunteers Overseas. In his free time, he enjoys reading, exercising, and spending time with family. So now we're going to go ahead and pass the floor over to Dr. Patel.
Thank you, Kayla. Good afternoon, everyone. Very happy to be here presenting this really important topic on breast cancer awareness. Just want to reiterate, how important the work the Women's Fund does in promoting health advocacy to women, all across the region. It's perhaps nowhere is it more important in conditions as important as cancer. Breast cancer, especially, requires really a two-way street between the care team, which includes physicians like myself, but also our nursing team and our infusion staff and radiation doctors and radiation therapists and surgeons and their staff members as well. So it's this coordination of care that's really critically important. And so, the work that the Women's Fund does to put together lectures and talks like this is really important work because it sets the groundwork for, how can we be our own best advocates when it comes to our care. So we'll talk a little bit about that today and within the larger context of breast cancer awareness, and that's what we'll be talking about today. So breast cancer is the most common cancer diagnosed in women in the United States. It is the most common invasive cancer, right? The only cancer more common than breast cancer in women is skin cancer, but the majority of skin cancer is relatively non-invasive and easily cured. Survival rates have increased for breast cancer over the course of decades. And the reason for that is in part because of early detection, which we'll be talking about today, and also because of improvement in treatments and coordination of treatments across multiple disciplines. So what is breast cancer and why does it happen? So what goes wrong in breast cancer is that there can be cells within breast tissue. The breasts are essentially just glands that produce milk. So breast glands contain lobules and also contain ducts. So that's the normal anatomy of the breast. The lobules produce milk and the ducts carry the milk up to the nipple. And so what goes wrong is that the cells that normally make up that tissue can proliferate and then become cancerous. Those cancerous cells grow in an immortal way without any checks or balances, and then can sort of take over that tissue, right? So if breast cancer occurs in the lobule, that's called a lobular breast cancer. And if breast cancer occurs in the duct, that's called a ductal breast cancer. The more common of the two is ductal cancer. And the other distinction that I think is important for folks to know is the distinction between non-invasive breast cancer and invasive breast cancer. So, you know, if your doctors were to talk to you about the type of cancer someone has, they would make sure to be clear about that distinction, right? Non-invasive breast cancers are ones that are occurring within the empty space of the duct or the lobule, right? So if you think about the way a lobule would be shaped, it's a gland, so it has an empty shape, right? An open shape, and within that that lobule, you have cells on the inside of that are producing milk and secreting it into that empty space to be then carried by the ducts up to the nipple. But on the inside of that, of course, if there is a cancer forming, it would grow into that empty space. There's little resistance to growing into that empty space. But if it were to go through the wall of the lobule or through the wall of the duct and into the surrounding tissues, that's invasion, right? So that invasion is what allows access to the tissues deeper than the lobule and the duct, which are the blood vessels and the lymphatics, which can then allow the cancer cells to spread to other places. So a non-invasive cancer is how many breast cancers will start. So those will be the cancers that are growing into the empty space, the easy growth. And if we find it at that stage, that's called in situ cancer or non-invasive cancer, also known as DCIS, ductal carcinoma in situ, lobular carcinoma in situ. These are cancers that are generally much easier to treat, much easier to deal with. These are also called stage 0 breast cancers. And we can find these on mammograms as well. So if you're diagnosed with a non-invasive form of breast cancer, just know that the cure rates are essentially 100%. The only risk for those patients is the risk of potential new breast cancers in the future. So we talk about how to reduce risks for those. For invasive cancers, now these are the ones that have stages, right? Stages 1, 2, 3, and 4. And these are the cancers that can be more concerning in how we manage them and carry real risks of potentially coming back in the future in other places within the body. So we're more aggressive in how we manage them. And it's really important that we do everything that's appropriate medically to maximize someone's odds of cure for an invasive cancer. So that's generally speaking what goes wrong. And then why do cancers happen? Why do breast cancers occur? Well, it's a combination of factors. There's not one thing that is causing breast cancer. It is a combination of things. And so a combination of lifestyle factors, hormonal factors, environmental factors, as well as genetic factors may contribute to someone's individual risk of breast cancer. But the vast majority of people have cancers that are what we call sporadic, right? Sporadic cancers mean that there's no definable risk factor that that person was exposed to and no known genetic risk factor for that patient or their family, but yet they still develop breast cancer. So that's about 90% of all breast cancers that are what we call sporadic. So those cancers, we think, are caused by some combination of hormonal balances or imbalances, metabolic factors and lifestyle factors. So that can be things like weight and diet and lifestyle. And then environmental factors, things that maybe we can't totally characterize, right? Our exposure to things like pesticides and air quality, pollution, things of that nature, insecticides. These are all things that can potentially contribute to our collective and individual risks of developing cancer. So only 5 to 10% of breast cancers are attributable to genetic risk factors. So these would be genes that are passed down from someone's parents to them, which then confer an increased risk of developing breast cancer. So a minority of breast cancers are passed on with genetic risk factors, but they are important to consider, especially if you're someone who's diagnosed at a young age. Like if you're less than age 50 diagnosed with breast cancer, it's really important to think about whether there could be a genetic factor there. So these are the collective of risk factors for the development of breast cancer. All of these contribute in generally small ways to someone's individual risk of developing breast cancer. So I wouldn't say that any one of these is a specifically dominant risk factor, right? And you can see from the list that many of these sort of follow common sense, right, around what would lead to some risk of someone potentially being at risk for breast cancer. So being female, right? Pretty obvious risk factor. So women are much more likely to develop breast cancer than men. But I guess it's worth mentioning that men can also develop breast cancer, right? So men also have glandular breast tissue, and there's a small risk in men of developing breast cancer, but it's much, much more common in women. So therefore, just simply being female is a risk factor. Increasing age is another risk factor for development of breast cancer. So as we get older, it is more common to develop breast cancer as we age. So a common question that I get in my practice is, well, Dr. Patel, I thought that it's all about hormones. Like I thought that it's that when my hormones are high, or when I'm getting hormones through birth control pills or hormone replacement, that's what's causing risk. Like why would I, as a postmenopausal woman in my 60s, 70s, 80s, be at risk for breast cancer? And the answer to that is that yes, hormones play a role, but it's not the only factor. Age is probably even more of a dominating risk factor. So there are many more women who are diagnosed with breast cancer in their older age than there are generally in younger age. So breast cancer is, generally speaking, a disease of aging. And then personal history is important. So if you've had a breast biopsy before that found specific features like lobular carcinoma in situ, which we talked about earlier, LCIS, or if they found atypia specifically in your breast or in the tissues of your breast, then that carries some increased risk for breast cancer. So if you ever had a breast biopsy that shows one of these specific findings, then it's worthwhile to come meet with a medical oncologist like myself and talk about what risk reduction strategies could be considered to minimize your future risks of developing breast cancer. And then having breast cancer before is an independent risk factor for developing future breast cancer. So if you've had a breast cancer on one side, for example, then you have an increased risk of developing breast cancer on the other side. And that's an important thing. A lot of my patients ask me, well, Dr. Patel, does that mean that my breast cancer that I had on my right side, is it coming back on my left side? Is that what we're talking about? And the answer is that's not what we're talking about, right? What we're actually talking about is not so much that the original breast cancer metastasized to the left side. That's distinctly uncommon, right? What's more common is that someone has a right-sided breast cancer, for example, and then years later, she develops something on the left side that's also cancerous. And that's just because of accumulated risk factors, right? So those tissues have all been exposed to those same risks over the course of that woman's life. And so those tissues then acquire that risk of becoming precancerous and then later cancerous. And so when you've had one breast cancer, your risk of developing another is higher than the average person's. So we pay extra caution in our breast cancer survivors to monitor their other breast, right? I guess another important caveat to that is, well, then doctor, should I have both of my breasts removed? Like, is it critical that every woman have a bilateral mastectomy? And the answer to that is, if you have genetic risk factors, yes, it's worth considering bilateral mastectomy. But if you don't, the risk is not so high of developing a breast cancer on your other side that it would warrant or necessitate the medical risks and reconstruction risks and cosmetic downsides potentially of electively taking that opposite breast. But some women still choose to, right? So that's a conversation that has some nuance, and it's worth discussing that with your doctor if it's something you want to consider. And then another risk factor is family history. So if you have first-degree relatives like your mother, sister, daughter diagnosed with breast cancer, particularly if they're less than age 50, then risk is increased of you developing breast cancer. So again, as we discussed before, the majority of people diagnosed with breast cancer don't have any significant family history or a family history that's actually affecting their own risk. But it's still worth noting, especially if first-degree relatives have a history of it, or if they were diagnosed at a young age, especially. Other risk factors include specific inherited genes. So these are genes that many of you have heard of, things like BRCA1, BRCA2, PALB2. These are all genes that can be passed down within our families. But again, only about 5 to 10% of all breast cancers are actually caused by these sorts of variant genes. So they don't inevitably cause cancer in people who have whose families are affected by these genes, but they do increase the risk. And so it's worth knowing if that's a possibility. Clinics like mine, we screen patients who are unaffected by cancer, but if they have a strong family history, we'll talk to them, those folks, about maybe having genetic testing, and if they meet certain criteria, then we'll send a blood test or a cheek swab to run these genetic tests. Radiation exposure is another risk factor for women, but this is specific to very certain groups of people who've had radiation treatment to treat things like lymphoma or other forms of cancer, especially at a young age. So people with Hodgkin's lymphoma who historically have had things like radiation treatments to their chest. those folks can have a higher risk of developing breast cancer in the future. But again, this is a pretty uncommon scenario for most people. This is not, this kind of radiation exposure is not the kind where, like, you know, you go through an airport or you fly in a plane or you're a steward or a stewardess. That's not the kind of radiation exposure we're kind of talking about here. It's much more intensive radiation exposures. Obesity is a real risk factor. Obesity is a very significant risk factor, and we think it's one of the big contributors to the increasing rate of breast cancer amongst our population. So being obese does increase risk. We think the reason is primarily because our fat cells produce estrogen. So that excessive estrogen that's being produced by fat cells might increase and contribute to our individual and collective risks. And so weight loss is an important risk reduction strategy. So if we could all maintain healthier weights, that would overall reduce our population incidence of breast cancer. And then early menstruation and late menopause, these two risk factors have to do with how much estrogen has your breast tissue been exposed to over the course of your lifetime, right? The earlier you have menarche, or the earlier you begin having periods, then that means your ovaries are starting to cycle and produce monthly cyclical estrogens. And then your breasts are being exposed to that cyclical estrogen exposure month after month after month as soon as you start having periods. So the earlier that starts, and then the later that finishes at the time of menopause, confers some additional risk. But again, these are small risk factors, not major risk factors. And then things like delayed motherhood, that's another risk factor related to timing of estrogen exposure and duration of estrogen exposure. When you're pregnant, your ovaries are no longer cycling, and that estrogenic stimulus and an on and off switch that's happening month to month is actually stopped for the 9 months that you're pregnant. And so that's why delayed motherhood, the later you have a child, in theory, the more unopposed estrogen you've had over the course of your adulthood to that time. And then having no pregnancies is also a small risk factor for the same reason. And then people who take exogenous hormones. So especially women who are post-menopause and take specifically high doses of hormone replacement therapy, there's some pretty significant risk of developing breast cancer in that population. So for women who are listening to this who may be post-menopause, it's just worth talking to your doctor. If you're thinking about going on hormone replacement, let's make sure we're dosing it carefully. Let's make sure we're using the minimal dose to achieve the effect desired of minimizing hot flashes and sexual dysfunction and menopausal symptoms. But let's not try to overdo it with the hormones, because there's the other side of that coin, which is that it can slightly increase the risk for breast cancer. And so if we can do that for as time limited as possible, so just for a year or two to get you through the acute symptoms of menopause, and then we stop it, but using it for year after year, or for decades, certainly we would generally advise against that if we can. And then alcohol is a risk factor for breast cancer as well. And we try to advise essentially no more than a drink a day, ideally no more than, if we can, something like a drink or two per week would be sort of the ideal. How do we reduce risk of developing breast cancer? Well, these are the four sort of main principles. So getting screened involves having a physical breast exam with your physician, and that could be your gynecologist, that could be your internal medicine doctor, your primary care doctor. It could be an oncologist like me if you have a need for one. So having clinical breast exams as well as mammograms are important. We'll talk about the cadence and frequency of those upcoming. And then breast self-exams are generally important. It's not totally clear how valuable they are, but I still think it's a reasonable thing to advise folks to do, right? So just having general familiarity with the way your breasts feel and what might be unusual for you mid-cycle versus late in the cycle for women who are still cycling, for women who are postmenopausal, just having a general sense of what is normal in the breasts as well as in the lymph nodes nearby are helpful, so that you can bring up any unusual signs or symptoms to your physicians. And then limiting alcohol, we talked about that. Ideally no more than 1 drink a day, and ideally if you can get as low as 1 or 2 drinks a week, that would be even better. And then exercise, right? We talked about the importance of weight management, weight control, and the contribution of excessive obesity and our peripheral fat to estrogenic stimulus on the breasts. So if we can exercise and control diet, that's a good way to reduce risks. And exercise may have additional metabolic benefits that reduce our risk separate just from fat reduction. Limiting hormonal therapy, we mentioned that earlier as well, so I won't go back into that. Maintaining healthy weights, we've talked about, and then eating healthy. So what kinds of food should we eat, right? So we know that the Mediterranean diet seems to be to have the most science to support its use in reducing cancer risks and cardiovascular risks. Although we all know, we read articles every day, every week, across all of our devices and every social media we consume are on what's the right diet, what's the right way to lose weight, what's the right way to maintain our weight, what should we eat, what shouldn't we eat? Should I drink green tea? Should I drink black tea? Should I drink coffee? Should I drink, some other extract? What about goji berry juice? What about this? What about that? I'd just say that the individual studies you might see out there can be very confusing. And I think it's probably better if we can just to kind of tune out a little bit of that noise when it comes to diet, if we can. And just generally speaking, if we can eat whole foods, real foods, that's step one. So if we can just eliminate some of the processed foods that are in our diets, I think that would probably be step one for the majority of us. So limiting and minimizing processed foods. So that's kind of like anything that comes to us in a box, right? A box or a bag or some kind of packaging. If we can kind of minimize that and kind of focus on foods that we have to kind of cook ourselves, prepare ourselves at home, those are generally going to be healthier choices for the majority of us. And then Mediterranean diet specifically focuses on plant-based foods. So if we can enrich the plant-based composition of our diet, that's probably an important strategy. I'm not someone who really advocates a lot around avoiding meat intake. I think meat probably has a very healthy role in our diets to provide protein and provide balance. And if you choose to be vegan or vegetarian, that's perfectly fine too. But finding protein sources is probably important for those folks too, through lentils and legumes and beans and so on. So balance is probably the key when it comes to diet. And then as far as supplements are concerned, I don't think there's a lot of good science or data around specific supplements that are adding value. So I tend not to recommend a lot of supplementation for my patients. I don't think there's tremendous data or science to support that. So we don't do that. And then in terms of high-risk strategies, for patients who have specific risks, high risks, so those are a specific group of patients. These would be patients who maybe have had LCIS or breast atypia, or who have specific genetic risk factors. Those are considered high-risk patients, right? Not everyone is high risk, but for people who are, then they would come to a medical oncologist like myself, and we would talk about preventive strategies, right? And these preventive strategies would include some of the lifestyle things we talked about, screening that we talked about, breast exams and mammographies, possibly MRIs, but also we would talk about the possibility of preventive medication. So these would be estrogen blockers, things like tamoxifen, raloxifene, aromatase inhibitors. These are all medicines that can reduce the risk in women who have a high risk of disease. So if someone with high risk, that means that they have about a 20% or higher chance of developing breast cancer over the subsequent 10 years. So if you have a high risk, like a 20% more or a 20% or more chance or odds of having a breast cancer over this next 10 years, by going on to a pill like tamoxifen, we can cut that risk in half or more. So from a 20% risk, we can reduce that to a 10% risk or less. And then preventative surgeries can also be considered, especially in women who have genetic risk factors. So preventative mastectomies can be considered. Again, these are generally considered mostly in women who have clear genetic risk factors. So those are BRCA1 or BRCA2 mutations. And if you have those, then the risk of developing breast cancer over the course of your lifetime is in the 50 to 80% range. And so that's a pretty high risk. And so in that case, choosing prophylactic bilateral mastectomy is a reasonable consideration. Whereas for many other women with high-risk conditions, the risk is only around 20% of risk. And so therefore, doing bilateral mastectomy is often not medically recommended or suggested, but some women can still choose to do it. And then prophylactic oophorectomy is taking the ovaries, where that can also be considered for women with specific genetic mutations like BRCA1 and 2. And so those are things to consider if you have those specific genes. So what are the symptoms of breast cancer? How would we know if someone has it? Well, we all generally know the scenario of potentially finding a lump. That's a common way for breast cancer to be diagnosed. But actually the most common way nowadays is that a woman doesn't feel anything at all. She just comes in for her annual mammogram and is told that there's a shadow seen or some new group of calcifications or a new lump or mass that's been identified on her mammogram. And so sometimes that's a change from the prior year. Occasionally it's the woman's first mammogram, but it's more common that it's that woman's follow-up mammogram a year later that's showing something that may be new. And that's how most breast cancer is diagnosed nowadays. It's on mammogram and through mammographic findings. But for women who maybe aren't doing mammograms or have yet to start, Then breast lump and breast thickening of the skin is something that can be seen and noticed. So if you notice anything like that, that's something to bring to your physician's attention. And then a major change in the size, shape, or appearance of the breast. So if the breast is suddenly red, if the breast is suddenly significantly swollen, even if you don't appreciate a mass within it, those are things to bring to your physician's attention. And then changes in that skin, again, like dimpling in a specific area of the skin, even if it's painless and you otherwise feel fine and don't feel a lump. If there's dimpling, that's something to bring to attention. Inversion of the nipple, again, could be a benign thing, but can also be an early sign of cancer. So those are things to bring to attention. And then peeling, scaling, crusting, flaking of the areola, which is the nipple, and or any kind of new significant skin change on the breast. Those are things to bring to attention. And then again, redness or pitting of the skin of the breast, which would be like a orange peel sort of appearance of that breast skin. That's an important finding to bring to attention as well. You'll notice that on this list, pain is not a big symptom of breast cancer, right? So a major concern that I see in my clinic a fair amount is both in breast cancer survivors and in women who are at risk is that they report pain in their breast and they're concerned that that might be cancer. I wouldn't say that that's never the case, that a woman with pain never has cancer. That's not totally true either. But in the majority of breast pain, if it's not accompanied by other symptoms like a lump or a mass or redness of the skin or some other clinical finding or physical finding, most breast pain turns out to be benign. And so I tend to reassure most of my patients with breast pain or breast tenderness that that's an unusual way for breast cancer to present itself. Let's talk about treatments. So treatments for breast cancer consist of generally what I describe to my patients as 4 pillars of breast cancer therapy. Each person doesn't necessarily need all 4 of these treatment pillars, but it's important just to think about all 4 of them for everyone that you see who might have breast cancer and consider them in sequence, because potentially people can benefit from all 4. So the 4 pillars of breast cancer treatment are surgery, chemotherapy for people who need it, radiation therapy for people who need it, and then the last pillar is anti-estrogen therapy or hormonal blockers. So these are the 4 general pillars of treatment. And within that chemotherapy pillar includes targeted medicines. So that could be targeted medicines for things like HER2. So there's a subset of breast cancer that's HER2 positive. And if you have a HER2 positive breast cancer, then you would definitely benefit from getting a HER2 antibody like Herceptin or Perjeta. And so within that chemotherapy pillar, I also would always consider the biological drugs as a component of that pillar of treatment. Let's talk about surgery. So surgical treatment, there are 2 different the 2 main types of surgery that any woman with breast cancer would be considered for are a lumpectomy or a mastectomy. So a lumpectomy is also known as a partial mastectomy. And so that means that you're taking the portion of the breast out that contains the cancer, right? So not every woman with breast cancer is a candidate for a lumpectomy, depending on the size of the tumor, the location of the tumor within the breast, and the general size of the woman's existing breast tissue, right? So if your tumor is especially large, or if it's right behind the nipple, or if the existing breast is on the smaller side, then it may not be ideal to consider a lumpectomy. But the vast majority of women actually are generally eligible for lumpectomies. So lumpectomy is an important option for treating breast cancer and is often the sort of operation of choice. Because it leaves the woman's natural breast largely intact, and you can get a great cosmetic outcome in terms of having your natural breast tissue and natural breast shape and so on, and you can achieve really good symmetry with the opposite side. And so a lumpectomy is a very reasonable way to treat breast cancer. What's important to know about a lumpectomy is that if you choose to do a lumpectomy, then in general, most women would also benefit from having radiation after that. So in general terms, and this doesn't apply for everyone, but for many women with breast cancer, if you do a lumpectomy plus radiation is equivalent to the outcomes we can achieve with a mastectomy. Now, the older we get, so for example, for women over age 70, there's much less benefit to considering radiation after lumpectomy, but that's an individualized discussion that you would have with your radiation doctors and with your oncologists. So the bottom line is that a partial mastectomy is a really good option for many women. And the cosmetic issues afterwards are that the tissue removal might change the look of the breast or the shape of the breast. But in general, the surgeons do a great job of trying to minimize that cosmetic impact. So sometimes you'll do things like tissue rearrangement to fill in the little bit of a defect that you might experience and so on. The other surgical treatment is a mastectomy. So that there are two different flavors of that. One is a total simple mastectomy and the other is a modified radical mastectomy. For most women with breast cancer, if the lymph nodes are not involved, they need a simple mastectomy and a sentinel lymph node biopsy. And so the bottom line is removing the entire breast is a component of that surgery. And then we can offer reconstruction. So reconstruction, there are different versions of that as well. So reconstruction means taking either tissue from your own body, that's called autologous reconstruction, or taking an implant and then creating a new breast out of either an implant or out of your own tissue, typically taken from your belly or from your back or from your upper buttock. And so that's a mastectomy. And so a mastectomy can lead to really good both cure outcomes, but also can lead to great cosmetic outcomes, right? When women go through reconstruction, if they choose to. And many women choose not to undergo reconstruction, right? So it's also totally okay to have a mastectomy and not do reconstruction, right? So the reconstruction decision is one that's very nuanced, very individualized, and really something to discuss in detail with your surgical team, which often will include a plastic surgeon. Chemotherapy. Chemotherapy is the second pillar of treatment, and not every woman needs chemotherapy, right? In fact, nowadays, the majority of women with breast cancer do not need or benefit from chemotherapy. And that's because the majority of breast cancer that we diagnose is diagnosed in early stage, number one. And number two, 80% of all breast cancer is hormone receptor positive, like ER/PR positive, and negative for things like HER2/neu. So if you have that kind of breast cancer, which is the most common type, then the majority of those patients actually don't really benefit from chemotherapy, provided their lymph nodes are negative, and we use some genetic testing like called Oncotype DX that helps us further stratify whether patients really benefit from chemotherapy or not. So again, nowadays, a significant majority of patients don't need chemotherapy. But if you're in the group of patients who would benefit from it, there are real benefits, right? So I would encourage everyone that's on the call today to really think about this and heed the advice of your oncologist to really consider it. Because if they're recommending it for you, it means that you're part of a group who would derive real benefits in terms of improving your odds of being cured, right? So if you have hormone receptor positive breast cancer, HER2 negative, and your Oncotype score comes back high risk, then it's really worth considering chemotherapy because we can reduce the odds of you experiencing a metastatic recurrence, a stage 4 recurrence, by more than 50% by going through 3 to 5 months of chemotherapy. Similarly, if you have a HER2 positive breast cancer, you can reduce the odds of having a metastatic stage 4 recurrence by more than 50 or 60% by accepting a few month course of chemotherapy. And if you have triple negative disease, it's critically important to really think about chemotherapy and immunotherapy to maximize your odds of cure. So it's really important to think about what your individual risk is and talk with your oncologist about what they really think and how they would couch that risk. Because there's real benefits to chemotherapy for the people who need it. So I think one of the big successes in oncology over the last 10, 20 years is that we've gotten a lot better at understanding who really benefits from chemotherapy. Because we don't want people to have to experience the toxicities and side effects of chemotherapy if we can avoid it, right? So one of the big advances of modern oncology is that we're really narrowing the groups more carefully and understanding who really benefits from it, who doesn't benefit from it, so that we can spare the people who derive minimal benefits from it and enrich the benefits and maximize the benefits in the people who really will need it. And so when we need chemotherapy, it's really helpful. And the way generally it's given is over the course of somewhere between 3 and 6 months in general. It's given in the form of cycles, which your oncologist will call it a cycle, which means that we infuse the chemotherapy drugs, typically through a port, which is a small plastic button underneath somebody's collarbone connected to the veins in their chest. And the chemotherapy is infused over the course of a few hours, typically once every 3 weeks. It can be anywhere from weekly to once every 2 weeks to once every 3 weeks, depending on which regimen is being recommended for you. And each cycle is measured in that number of weeks. And then we continue that for somewhere around 3 to 6 months, again, depending on the specifics of your regimen. And then all these chemotherapy drugs are given in an outpatient setting. You don't need to be hospitalized for these. It's rare that people need to be hospitalized nowadays due to complications from chemotherapy, especially for breast cancer, right? We use these drugs all the time. We're very familiar with them. So we know how to support our patients through them and keep them out of the hospital. But there is some risk, right? There's risk of nausea and vomiting. There's some risk of diarrhea or constipation. There's some risk of fatigue and tiredness. There's some risk of mouth soreness or taste changes, appetite issues, and there's some risk of hair loss. But these are all predictable and manageable. So most people are able to work full time despite being on chemotherapy. So people are able to go to work, live their generally normal lives, and are able to live despite these side effects reasonably normally. And then radiation therapy is the third pillar of treatment for breast cancer. And again, radiation therapy, similarly to chemo, we have gotten better and better at trying to understand who really needs it, who really benefits from it, and then only deploying it for those people, right? So, and here at Kelsey, we do a great job of trying to really understand that deeply and sparing people from who do need it, then we give it, right? And we really encourage people to consider it. And for folks who don't need it, we really try to avoid it because we don't want to, again, expose people to side effects unnecessarily. So, on this slide, you'll see one of the machines that we have here at Kelsey. All of our Kelsey radiation facilities contain this particular machine, which is called the Varian TrueBeam. The bottom line is that this is, how we deliver radiation is really important, right? And having great equipment and great radiation oncologists with great support and physicists is what makes radiation therapy world class. And so having the right plan and the right what we call fractionation schedule, which is how the radiation is going to be delivered exactly, is really important. And improving the accuracy of that radiation so there's as minimal risk to adjacent tissues as possible is really critically important. And so preventing that damage, on this slide, we're talking about breath holding techniques and how we do that here at Kelsey-Seybold. Breath holding is important because it allows us to spare adjacent tissues and minimize radiation dose to the heart and other important structures. So it's very important, and we have all that kind of technology here. In terms of other forms of radiation, there's something called hypofractionation now. Hypofractionation means doing a higher dose of radiation for each dose that someone's here for radiation treatment, but doing it for just, for example, 5 sessions. So instead of having radiation conventionally for 6 whole weeks, coming Monday through Friday with Saturday and Sunday off, we have to come in every day for half an hour every day for those 6 weeks. Now, for some people, and in some scenarios, we can offer just 5 days of radiation treatment where it's a lot less impactful to your schedule and to life. But it's also great in terms of the cosmetic outcome and in terms of how people feel on it and side effect burden and so on. So the advances in radiation technology and techniques are continuing to just accelerate. And so we're seeing our patients get a lot of benefit out of these new strategies. And then before I conclude, I just want to mention anti-estrogen therapy very briefly. That's the 4th pillar of treatment for breast cancer. Anti-estrogen therapy we talked about a little bit earlier as a preventative strategy for women at high risk, but it's also really important in women with hormone receptor positive breast cancers because that's the last part of their treatment, right? After they go through their surgery and possibly chemo and possibly radiation, then they'll be a candidate for anti-estrogen pills. And these are really important. This is really the 4th leg of a table, so to speak, where each leg of that 4-leg table can be really important for the people who need it. And so, although taking a pill, daily for 5 to 10 years can sound a little bit daunting, in general, the side effects from these hormonal strategies are pretty manageable for the majority of people, right? So if you go on the forums and you see how people are doing with breast cancer and with treatments, you'll often see people reporting their symptoms of their anti-estrogen therapy. And it's, of course, those symptoms and side effects are very real. But what you often won't see on some of the forums is the women who've gone back to work and who have gone on and don't have a ton of side effects because they kind of feel guilty to post that, hey, I'm doing okay on my hormonal therapy. So you don't see the whole picture sometimes. So I try to encourage my patients that, especially on the forums and things, just be mindful of the experience you're seeing is one person's experience. And no matter how good or how bad it may seem, people can be a little bit hesitant, understandably, to post positive experiences. And it's understandable because they have some form of survivor's guilt, right? No one's going to be out there saying, oh, look at how great I'm doing on my tamoxifen, because they feel poorly. There's many folks out there who aren't feeling as well. right? So we just have to think about that whole spectrum. What I tell my patients who are going to start these drugs is that there's some risk and there are some downsides, and I'm as transparent as I can be about what they're likely to experience. But that starting it doesn't cost a lot, right? It doesn't take a lot to try it out, see how you feel on it. And then if you're not feeling well enough for whatever reason, then talk with your doctor about different strategies for how to mitigate those side effects or help reduce them. Because often just a few months onto them, people notice that just like being on birth control pills or something else that's hormonal, you adapt to them. Your body adapts to that new hormonal environment, and life goes on. So anti-estrogen strategies are really important, and something I just wanted to mention as well. So that concludes my talk today. I really appreciate everyone's attention. If there are questions from anyone who's online, I'm happy to answer them.
Yes, so thank you so much for that presentation. If you do have questions, you can feel free to add them into the chat, or if it's a little bit easier, you can unmute yourself to ask your question. I will go ahead and kick us off with the first one. So you mentioned hormonal factors contributing to risk for developing breast cancer. Can you speak about whether or not someone who is taking birth control would have any risks?
Yeah, so the short answer to that question is for women who are on birth control pills, premenopausal women, generally speaking, the risk of developing breast cancer due to what we call OCPs or oral contraceptive pills is low. So, generally speaking, I'm not too worried about those women. So women who need birth control pills for some period of time during their premenopausal years, we think that's pretty safe overall, right? The one risk about OCPs that's worth discussing with your gynecologist is the risk for things like blood clots, things like that. There are some real risks there. So that's worth discussing, especially if you have a family history of blood clots or certainly any personal history of blood clots, that's worth discussing. Breast cancer risks, not such a big concern with oral contraceptive pills in premenopausal years. It's really more about hormone replacement therapy for women who are postmenopausal. So when you're postmenopause, then estrogen levels drop when the ovaries turn off, and then when we try to replace those hormones, there seems to be more risk of developing breast cancer. One, because of course that woman is a little bit older now, so she's accumulated years of breast stimulation over the course of her natural cycles. And then on top of that, now you're going to put in unopposed estrogenic stimulus through hormone replacement therapy, and there's some risk there. Do I think that risk is so dramatic that no one should be on hormone replacement therapy? Not anymore. I used to think that when the data first came out, 15 years ago or so, we were very adamant in the oncology community that really no one should be on hormone replacement therapy, and it's clearly increasing the risk of breast cancer. But I think there's nuance there to that conversation that we've learned over the last 10 years or so, which is that there's some women for whom menopause is just miserable, right? And for those women, hormones can be really helpful at improving quality of life. And so it's just a conversation that we should have with our patients to say, well, menopause is making you miserable right now, and it's really affecting your quality of life in meaningful ways. And if it is, then there's a simple fix, which is to put you on a low dose of hormone for a period of time, but a defined time. And so what I try to say is we just don't want people on hormone replacement therapy for a decade, for 5 years, 10 years, 20 years, because then it's unopposed estrogen for years and years. And we know that those women really do carry some real risks. But the challenge is that the hormones really do make us feel good, right? You put me on testosterone, put y'all on estrogen, and we feel great, right? But the problem is there's some downside, right? The downside in men is that excess testosterone can lead to prostate cancer risk, and in women it can lead to some breast cancer risk. So all in balance is the approach that I would advocate.
Thank you. We have 2 questions online. The first one is, can you talk a little bit more about triple negative breast cancer?
Yeah, sure. So triple negative breast cancer has thankfully seen some advances, over the last 5+ years. Triple negative breast cancer, the sort of take-home points that I would want this group to know is that it is the most aggressive form of breast cancer, right? It is disproportionately affects people who are African American and Hispanic. We don't know exactly why that is, but there seems to be truth in that it disproportionately affects folks in those ethnicities. And because of its aggressiveness, we also have to in turn be very aggressive in how we manage it. The reason it's so dangerous is because these cancer cells grow independently without needing to be stimulated by anything. They don't feed on estrogen, for example, or on progesterone. And they don't have any, they don't carry any markers on their surface that we can very easily target. Like HER2, for women who have HER2 positive breast cancers, that's a very targetable marker. Thanks to that marker, that protein being present, we can attack that protein with drugs that are specific to HER2. Triple negative breast cancers, unfortunately, don't have those kinds of targets that we can easily drug. And so we have to find other solutions. And so the solution that, the most recent solution that's been found has been to add immunotherapy. So trying to harness our own immune system to try to attack those cancer cells. And that's actually been one of the most effective strategies and newer strategies to date, which is to combine chemotherapy to treat these cancers with immunotherapy. So for people who have triple negative breast cancers that are over 2 centimeters in size and or node positive, those patients will get a combination of chemo and immunotherapy. And typically we'll administer that before they have surgery. So that's called neoadjuvant chemotherapy. So we do it first before you have surgery. And the purpose of doing it first is so that we can shrink the cancer prior to operating. And then when we do your surgery, we'll find out, right? Did the cancer completely disappear? About 50 to 60% of patients will have the cancer be completely gone when we do their surgery. And that's a great sign, right? If we see that, that improves the odds that that patient will remain cured forever. And for patients who still have some residual cancer, then we have other options to consider after surgery, right? We'll continue the immunotherapy for sure, but also we'll consider adding a pill-based chemotherapy called Xeloda and other strategies to minimize their odds of recurrence. So triple negative breast cancer is, it's the most aggressive and risky form of breast cancer. And as a result of its risk, we are also more aggressive in its treatment. So if you're diagnosed with triple negative breast cancer, I would advise you try not to be fearful of it, but be prepared that it's a fight, and we're here to help you fight it. And the way to do that is to be aggressive in turn, right? We don't want to sit back and miss opportunities to potentially maximize the odds of cure up front for that kind of cancer.
Thank you. The next question was, if you have dense breast, is that a risk factor for breast cancer?
Yeah, so what you'll start to see on your mammogram reports is more scoring of breast density. So you'll see in some of the new, most of the imaging centers, ours included, you'll see a scoring system now specific for breast density. And so as that scoring goes up, if you have clearly dense breasts, then if that plus some additional familial risk factors, then we might consider you high risk. And so then come talk to us, right? Bottom line is come talk to an oncologist, talk to your gynecologist. Do I meet criteria for things like breast MRI, right? Suffice to say, breast MRI is really sensitive. So the problem with breast MRIs is although it can pick up cancers well, it also picks up schmutz and stuff that's benign, right? So you end up getting a lot of biopsies. So that's the problem, is that we have technologies like mammograms that are really good to pick up breast cancer, but not quite as good when you've got dense breast tissue, right? And then you've got technologies like MRI that are almost too sensitive. You pick up a lot of cancer, yes, but you also miss and pick up a lot of benign stuff that then you've got to pursue biopsies on. And for women who've gone through biopsies and come back normal, many of them say, well, it's no big deal, you have to go for a biopsy. But for many women, it's terrifying. You go through a biopsy and it's benign, and it's like your life is, just come crashing down while you were waiting for these results to come back negative, right? And so it's very traumatic to have a negative biopsy. So what I would say about dense breasts is talk to your doctors, read your mammogram reports, understand where you stand on the scale, right? And then if you do have dense breasts, consider talking to a gynecologist or to an oncologist like me about whether you meet the criteria for high risk, in which case then we would talk about lifestyle modification, possible genetic testing, maybe incorporating things like breast MRI as part of your surveillance and monitoring.
Kind of going off of that, can you talk about recommendations for screening as far as age goes? Because I know it's very individualized based off of your risk factors, but just kind of what those recommendations would be.
Yeah, so in general, the U.S. Preventive Health Task Force generally recommends doing mammograms starting at age 40 for most women. and doing them every other year between age 40 and 50. So starting at age 40 and doing them every other year for 10 years through age 50, at which point then annual mammogram is what's recommended for most women. And so, and some women at age 40 choose to start doing mammograms annually, right? So the American Cancer Society recommends annual mammograms starting at age 40. So you can see how different groups might recommend different things, and it gets very controversial. And even in the scientific community, like in the academic scientific community and my community of oncologists, it is a controversial area, right? Where some groups of physicians feel like mammograms are really moving the needle in helping us diagnose cancers earlier, where we have the best chance of curing them. And other groups of doctors, including some of the largest data sets we have on mammograms, don't necessarily support the idea that mammograms are improving the overall health of our whole population of women who are undergoing. So the data is a little bit conflicting and sometimes a little bit confusing to interpret. So you'll see lots of different news stories out there about, groups of doctors disagreeing with mammograms and their utility and value, and groups of doctors being very strongly in favor of their benefits. So like everything, I think you guys have heard from me a few times now that I believe in balance, right? I think we have to think about both sides of that equation. And we just need to be reasonable about where the truth probably lies. Whenever we see extremes, the truth is often somewhere kind of in the middle, right? And so I would say that I think that every other year strategy for most women in their 40s, very reasonable, right? And for women who are potentially higher risk, like they have a primary family, an immediate first-degree family member with a breast cancer history at whatever age, then she should start getting mammograms every year starting at age 40, right? Or at least 10 years before her relative was diagnosed. And then for women, otherwise at age 50 and up, I generally recommend women to get a mammogram every year. Women who are over age 75, the benefits of annual mammograms beyond that age are questionable, right? It's a question mark. Generally, the healthier you are in your mid-70s, the more value there might be to finding a breast cancer. And if your health is borderline or not as great, well, then finding a breast cancer may not be the thing that saves your life, right? Because you have other illnesses that also threaten you. So, so we have to use our judgment. That's why the guidance of your doctor is always best.
Thank you. So the last question that I always like to ask is, if you had one thing that you wanted everyone who watches this presentation to take away, what would that one thing be?
That's a good question. The one thing I'd want the folks on this call to know is that breast cancer is really important, right? And there's a lot of information out there in the world around breast cancer and around all things health now. And I think my strongest recommendation would be to find sources you can trust, right? There's a lot of sources out there, right? And all of us, I think we need to do probably a better job, myself included, of curating our sources of information, right? Because there's a lot out there and there's a lot of noise. And as much as you can, find sources you trust, right? And those sources in my world are things like the National Cancer Institute, cancer.gov, cancer.net. These are good websites where there's good information out there about what is scientifically proven and supported. And then also put trust in your doctors, right? Find doctors that you trust. If you need to get a second opinion or even a third opinion, get them, right? That's worth doing, because when you find a doctor that you can trust, that's a relationship that you're going to invest in then for years, right? So I think those are the two big things. Would be let's curate our sources of information as best we can, and then number two, let's find doctors that we can trust, right? And let's build a relationship with them that's bi-directional, right? So that you're bringing your best to it and your doctor's bringing their best to it.
Well, thank you so much for that presentation, Dr. Patel. Before we leave, I just want to put this out there. If you're like me and you think of questions or comments after the fact, you can always email us at healtheducator@thewomensfund.org, and we will work to get an answer to your questions. I would also really appreciate if you would take a few moments to complete our survey. This will give us some feedback about what you liked about the presentation and maybe where we can make some improvements. And I will be sending out the survey link in a follow-up email. And lastly, I have our social media sites. Feel free to check out our social media pages, our websites, if you're interested in learning more about the Women's Fund and some of the upcoming events we have. We do have 2 presentations coming up on our schedule. One is on Monday, October 23rd. We're going to have a doc talk titled "What I Would Tell My 35-Year-Old Self." And our final awareness series of the year will be November 15th. And the topic is diabetes prevention and management. So these registration links are available on our website. Again, thank you so much for tuning in, and we hope you have a great rest of your day.